Hi. Rational use of antibiotics in the NICU is an important issue both to improve the intact survival of newborns and also to decrease the emergence of drug resistant microbe. In this podcast, we will learn the following: when to use antibiotics and when not to use. If a baby is clinically suspected to have infection, how do we choose the right antibiotic? That is choosing the empirical antibiotic. How do we and when do we upgrade or downgrade the antibiotics? If we get the culture report and the sensitivity pattern, how do we choose the most appropriate antibiotics then? How do we restrict the use of antibiotics overall in the NICU? And then we'll learn the optimum dosing and administration of some of the most common antibiotics used in the NICU. When not to use antibiotics. This is very important to avoid unnecessary use of antibiotics in the NICU. Some of the conditions which would force us to use antibiotics but where antibiotics have no role are a preterm baby admitted to the NICU without risk factors. However, antibiotics are indicated if a reason for prematurity is preterm premature rupture of membranes. In all other conditions, if the baby is asymptomatic and if there is no PPRM, even if it's a preterm, there is no need for antibiotics. There is no need for antibiotics in all asphyxiated infants or in babies who are symptomatic because of meconium aspiration syndrome, babies admitted for severe jaundice, and in babies who are admitted for surgery. In all these conditions, antibiotics are required only when there are predisposing risk factors such as foul smelling liquor, maternal infection, maternal fever, maternal tachycardia, repeated vaginal examinations, and so on. Now, next is to know when do we start antibiotics. In a symptomatic baby, we start antibiotics if the baby is having respiratory distress, but there is no clear-cut etiology. We are unable to identify the etiology even on clinical examination or from the routine tests which we do in the immediate NICU admission. Or if a baby is symptomatic and has clinical signs of sepsis such as off color, cold peripheries, prolonged capillary refill time, fever, multi-organ dysfunction, or if a baby looks sick otherwise and there is no evident cause. In these conditions, you are justified in starting antibiotics. Antibiotics are also started if there is clear-cut pneumonia or the chest X-ray. In an asymptomatic infant, antibiotics are required if it's a preterm and there was preterm premature rupture of membrane. In a term infants, antibiotics are given only if there are risk factors and if the screen is positive or if the baby is symptomatic. So, this is in term babies you start antibiotics when a baby is symptomatic with having risk factors or if he is risk factors and screen positive. In all babies who have culture positive sepsis, we would start antibiotics. Now, how do we choose the antibiotics when we have clinically suspected infection in a baby? For this, we have to understand that there are different categories of antibiotics which work against different microbes. Overall, the microorganisms which cause infection in the NICU can be categorized into gram-negative infections, gram-positive infections, fungal infections, and anaerobic infections. When our aim is to cover the gram-negative infections, we would use either aminoglycosides such as amikacin, gentamicin, or cephalosporin, or ampicillin, or pipericillin, or ciproflox, or meropenam, or colistin. Using one antibiotic in this category is sufficient to cover the gram-negative infections. If our aim is to cover the gram-positive infection, we would use either cloxacillin, or vancomycin, or ticoplanin, or tigecycline. If our aim is to cover the fungal infection, we should use either fluconazole or amphotericin. If our aim is to control the anaerobic infection, we will use penicillin or metronidazole. Overall, in newborns, there is overwhelming infection with gram-negative infections. Gram-positive infection would be most of the time nosocomial or would occur after prolonged hospitalization. Fungal infections would usually occur in high risk babies such as babies who are extremely low birth weight, on multiple medications, multiple lines. These are the babies who would have fungal infections. Anaerobic infections are usually rare in the neonatal period. Now, the next step is to how do we choose the appropriate antibiotic when we have clinical sepsis. For that, we have to know the microbes and their sensitivity pattern. So, for knowing the microbes which are prevalent in our NICU, we need to have a data of the last 3 to 6 months of audit of our blood cultures. And based on the audit, we know which are the common organisms and what is their common sensitivity pattern. Our aim should be to cover the most common organisms and use an antibiotic which would help us in killing that microbe. So if you know the organisms and if you know the sensitivity pattern of organism for the last 3 to 6 months or at least 30 to 40 cultures, then we would be able to justify using the appropriate antibiotic in our NICU. And for this, based on the audit, we can understand that our first line antibiotic should be that which has sensitivity for 70 to 80%. Second line antibiotic could be one where the sensitivity could be 80 to 90%, and third line antibiotic is that which would have a sensitivity more than 90%. It is a first line antibiotic we would start on, and we would upgrade to second line and third line only if the first line is not working or if our cultures are showing sensitivity pattern to a different antibiotic. Ampicillin and gentamicin is commonly used as a first line antibiotics in most NICUs, but in the West, the most common organism is group B streptococcus, and that is the reason ampicillin gentamicin is used in the West. In India, the most common organisms are gram-negative infections. So, to cover gram-negative infections, our aim should be use those antibiotics which cover the gram-negative infections like aminoglycoside, penicillin, or a cephalosporin or a pipericillin. So, our first line cannot be that which covers a gram-positive organism like group B, but our first line should be which covers the gram-negative infection. And if clinically there are pustules, abscesses and pneumonia and baby is symptomatic, then it is better to give a staphylococcal cover. Always avoid cephalosporins as a first line antibiotic, as this would increase the emergence of drug resistant bugs, both extended spectrum beta lactamases and also the resistant to other antibiotics also would go on if we increase the use of cephalosporins in our unit. The first line antibiotics can be usually from either an ampicillin or aminoglycoside like amikacin or gentamicin, or a pipericillin or pipericillin tazobactum combination. Now, once you started the baby who is clinically suspected to have infection with an antibiotic, how do you upgrade the antibiotic or downgrade the antibiotic? Usually, we should avoid upgrading the antibiotic in the next 48 to 72 hours if you clinically suspect and started the baby an antibiotic. Our aim should be to concentrate on supportive care to improve the outcome of this baby who is clinically suspected to have infection, and the supportive care should include maintaining euthermia, ensuring that the baby is not dehydrated or overhydrated, ensuring that his electrolytes like sodium, potassium, calcium are controlled. We should try to correct the acid-base balance by using either fluids or inotropes or blood transfusions if required if the baby has anemia. So, our concentration should be on supportive care rather than upgrading the antibiotics in the first 48 to 72 hours after starting the initial antibiotic. There should always be an unit policy as what should be our first line antibiotic and when we should go up on the antibiotic from first line to second line. Usually, the second and third line antibiotics should be upgraded to only when our cultures are showing sensitivity, or if he is a very sick baby and is not giving us adequate time for the antibiotics to act, or if even the clinical symptoms are persisting after 72 to 96 hours of supportive care and the first line antibiotic. How do we downgrade the antibiotic? Suppose we started a baby on a gram-negative, gram-positive and a fungal cover. Now, if we get a culture which is showing there is only gram-negative growth, then it is better to continue the antibiotic which cover for gram-negative organs and stop the gram-positive and fungal cover of antibiotics. So, one way is to see what organism we are growing and come down on the number of antibiotics we are using empirically. The other way is, after you get the culture report, look at the antibiotics which are antibiotics for which the microbe is sensitive. Now, based on the sensitive antibiotics, choose the one which has a narrow spectrum. And some of the antibiotics which have been chosen for gram-negative are aminoglycoside, pipericillin or ampicillin. For the staphylococcal, one would prefer to use cloxacillin over vancomycin, and for the fungal, one would prefer to use fluconazole over amphotericin. If the baby has clinically improved, we can try to continue the same antibiotic even if in vitro resistance is there, mainly because in vivo the antibiotic dosage may be different and the antibiotic may work in the tissue conditions better than in the vitro condition. However, this rule may not be applicable if a baby has grown Staph aureus, or if there is a Pseudomonas infection, or if the baby has meningitis. In these conditions, we should follow the susceptibility pattern on the antibiogram. Whenever meningitis is there, always understand the CSF penetration. There is no point in using drugs like quinolones or aminoglycosides for treatment of meningitis. We should use either penicillins or cephalosporins for good penetration into the brain and for correct treatment of meningitis. Now, the baby is started on antibiotics. We have sent a culture and the culture report is with us. Now, what do we do once we get the culture report and the antibiogram? Now, once you get this, choose one of the sensitive antibiotics. There is no need to continue all the sensitive antibiotics. One of the antibiotics for which the microbe is sensitive is sufficient. So, we can stop all the others and continue with one antibiotic. And that one antibiotic should be the one with the narrow spectrum. So, between ampicillin and meropenam, we would choose meropenam. Between Pipericillin Tazobactum versus levofloxacin, we would choose Pipericillin Tazobactum. Between fluconazole and amphotericin, we would choose fluconazole. And if the bug is sensitive to cloxacillin and vancomycin, we would choose cloxacillin. However, if there is intermediate susceptibility for one or two antibiotics, we can combine two antibiotics to get the best sensitivity pattern and ensure that the organism is becomes susceptible to the antibiotics. If one is using aminoglycoside for treating a bloodstream infection, it is preferable to restrict the usage of aminoglycoside to less than 1 week and hence choose an antibiotic where you can go for longer duration. Also think that apart from the type of organisms, also think the organism, the infection is at which site. As I said, if there is a CNS infection, choose an antibiotic which has good CNS penetration, and if there is a gut infection, choose an antibiotic which concentrates in the gut like ampicillin, and if there is a urinary tract infection, choose an antibiotic which concentrates in the urine such as aminoglycoside. So, apart from the narrow spectrum, apart from the type of infection, we also should decide the type of antibiotic from the tissue which is infected or the organ which is infected. Overall, our aim should be to ensure that we rationalize the use of antibiotic in the NICU, and this rationalization is otherwise called antibiotic stewardship. The principles of antibiotic stewardship are to restrict the usage of antibiotics, to restrict the usage of broad spectrum antibiotics like cephalosporins, meropenam, levofloxacillin or other quinolones, and to do a surveillance and auditing of cultures so that we can choose the right empirical antibiotic, and to have a protocol of antibiotic prescription in the NICU so that everybody follows the same rule of line 1, line 2 and line 3 antibiotic, and one should have infection control practices in place to ensure that we restrict our antibiotic usage and we get more of sensitive microbes. Now coming to the first step, how do we restrict the use of antibiotics? For this, there is no role of any prophylactic antibiotics. Even in any baby, there is no role of prophylactic antibiotics. Prophylactic antibiotics would in fact increase the risk of having drug resistant bugs. One another way of restricting the using of antibiotic is to believe more on the cultures and believe less on the sepsis screen. Using CRP as a guide to start antibiotics is not a good way of start using the antibiotics in the NICU. Always, all the units which are using antibiotics should have the culture of culturing the blood for microbes. So whenever we are starting antibiotics, it's a must that we send our blood culture, and apart from restricting the usage, we should try to restrict the duration of antibiotics, and for this the best way is 7 to 10 days for culture positive sepsis, 5 to 7 days in babies with pneumonia or babies who have started antibiotics because of symptoms and screen positives, 3 or less than 3 days in suspect infections, or stop the antibiotics in all clinical cases. When you get a negative culture, stop the antibiotic immediately. So believe on the cultures to decrease the duration of antibiotics. There should always be protocol on upgrading of antibiotics from first line to second line or second line to third line. Whenever one is upgrading from first line to second line or second line to third line, it is always better to take a second opinion. And whenever one is using the reserve drugs or third line drugs, it is better to involve the microbiologist, to involve the pharmacist, to ensure that we are giving the right antibiotic for the appropriate duration. Now, how do we restrict the use of broad spectrum antibiotics? So we already discussed that cephalosporin should never be the first line antibiotic, and as we have already dealt with it, that it increases the risk of emergence of drug resistant bugs and ESBLs. Aminoglycoside or Pipericillin Tazobactum are good first line antibiotics. Stop the broad spectrum. Even if you start a broad spectrum antibiotic, stop the broad spectrum cover once your cultures are available, and if you have a narrow spectrum antibiotic, choose the narrow spectrum compared to the gram spectrum. In gram negatives, we have discussed aminoglycoside and piperacillin are good, and in gram positive, cloxacillin is good. Downgrade the antibiotics once the culture reports are available, and the other thing is auditing of cultures every 3 to 6 months would help us in choosing the right empiric antibiotic. Surveillance and audit of the cultures is an important aspect to restrict the usage of antibiotics. Surveillance culture should be done from the unit, and we should try to audit the processes such as hand hygiene, IV cannulation procedures, usage of disinfectants, availability of disinfectant in the NICU. This would help us to know what is the burden of infection in our unit, and if you know our burden, we should try to decrease the burden of infection by preventive steps rather than by going for treating the infections. It is also must that we audit our cultures. We should know the organisms, we should know which organisms are early onset, which of them are late onset infections, so that we can see what antibiotic can be given to the mother and what antibiotic should be given to the baby as an empirical mode, and we should know the sensitivity pattern, and this will be known only by auditing of our cultures. So our first line and second line empiric antibiotic should always be based on our audit of our cultures. Now, the other important step of antibiotic stewardship is to have a protocol of antibiotic prescription, and for this we need to have a unit protocol, and every unit should use not more than 4 or 5 antibiotics in their NICU. And these antibiotics could be a Pipericillin Tazobactum, Amikacin or a Meropenam. For the gram negative, ciprofloxacin is often not used but can be used in reserve situations. Cloxacillin and Vancomycin for staph infection, and fluconazole or amphotericin for fungal infections. These are the minimum antibiotics which might be required for covering most of the infections in the NICU. Always document a change of antibiotic. If you are going from one antibiotic to other, kindly always document why these changes are needed, what was the reason, what was the clinical condition, what was the situation which led to this change of antibiotic. Always change should be under the control of consultant, so that inappropriately antibiotics are not changed just based on the gut feeling of an individual. Blood culture should always be done before any change of antibiotics. Even if you have started antibiotic a day before, if you are going to change the antibiotics, better to take the culture again, so that you know whether this antibiotic is going to be responsible for killing the microbe or not. The other important thing about antibiotic usage in the NICU is to know the antibiotics which we commonly use in the NICU, and also to know this prescription pattern. We are going to discuss some of the antibiotics which we commonly use in the NICU, that is cefotaxime, ampicillin, amikacin, ciprofloxacin, vancomycin, cloxacillin, Pipericillin Tazobactum, fluconazole, amphotericin and meropenam. So we'll see one by one. Whenever we talk about antibiotic dosage, we have to remember that the dose is based on the weight of the newborn, the age of the baby, the kidney function, other presence of other interfering drugs, and also the site of infection. So based on the weight can be categorized into less than 1.2, 1.2 to 2 kgs and more than 2 kgs. And the postnatal age can be considered as less than 7 days or more than 7 days. Based on these 4 or 5 parameters, one would decide the appropriate dose of antibiotic to be given for an individual baby. Coming to the first antibiotics, that is Cefotaxime, which is often used in the NICU, although should not be a first line antibiotic. Avoid it as an empirical first line antibiotic, as it induces antibiotic resistance or also fungal infections, increase the risk of having fungal infection. There should always be a caution when you use with Amikacin, as both are nephrotoxic. Cefotaxime can cause thrombocytopenia, neutropenia and eosinophilia. Now Amikacin, again it's a common antibiotic used in the NICU. Amikacin should always be given an infusion in 30 minutes, preferable to avoid the bolus infection of infusion of Amikacin. Drug monitoring is a must, especially after the second and third dose, as it has increased chances of having nephro and ototoxicity. It is preferred to give single dose Amikacin rather than splitting the dose into 2 or 3 doses, and preferable is to avoid the duration to less than 5 days. Amikacin, if you're using Amikacin, be careful when you're also using furosemide, vancomycin and cefotaxime, because these are also nephrotoxic. The nephrotoxic dose of Amikacin or levels of Amikacin is more than 10 microgram per liter, and the ototoxic dose is more than 35 microgram per liter. Ampicillin, it's another common antibiotic used in the NICU. Ampicillin should not be mixed with Amikacin. If you're giving Ampicillin and Amikacin, they should be separated by a saline flush. Ampicillin may cause thrombocytopenia, rash, and high dose of ampicillin can cause seizures in the newborn. Pipericillin Tazobactum, this is one of the commonest antibiotics used now in the NICUs. But remember that Pipericillin Tazobactum can cause thrombocytopenia, azotemia and liver dysfunction, which themselves could be signs of infection. So it might be difficult to differentiate the drug side effect from the infection, and Pipericillin Tazobactum can also cause cholestasis and hypokalemia as side effects. Pipericillin Tazobactum may be combined with Amikacin if one is using this antibiotic to treat Pseudomonas infection. It is not a preferred antibiotic for treatment of meningitis, as the penetration of this drug is poor into the meninges. Meropenam should be a reserve drug, and there should be caution when a baby has seizures and also has infection. It's preferable to avoid using Meropenam. However, Meropenam can be used to treat CSF infections because it penetrates the meninges well. Some of the known side effects of Meropenam are thrombocytopenia, leukopenia and anemia. And however, it is not licensed for use in children less than 3 months of age. But in the absence of other drugs, most units continue to use this drug for treatment of infection. Vancomycin is a drug preferred after cloxacillin, or it is used only when we have methicillin resistant staph aureus. It should always be given in infusion over 1 to 2 hours. A rapid push of vancomycin can cause cardiovascular instability and also serious problems for the newborn baby. Rapid infusion could cause hypotension, red man syndrome and a thrombophlebitis. One of the commonest side effects of vancomycin is neutropenia. Vancomycin can also cause ototoxicity and nephrotoxicity. Vancomycin can interact with amikacin, amphotericin, furosemide and indomethacin. In all this situation where you are using vancomycin with these drugs, you might have to reduce the dose of vancomycin by almost 50%. If you want to monitor the level of vancomycin, always take the level before giving the dose, because the trough level would be more important to judge the adequacy of dosage. Amphotericin B. Now, liposomal amphotericin B is preferred only when there is intolerance to conventional amphotericin B. There is no need to start amphotericin B for all newborns with fungal infection. Fluconazole is preferred, but if fluconazole is not the right choice, then plain amphotericin B should be the second choice. And then liposomal is preferred only when the baby is intolerant or if he has a kidney dysfunction, and plain amphotericin B cannot be given. If you are giving amphotericin, always dilute with dextrose, as it is incompatible with saline. The first dose should be over an infusion of 6 hours, and every day when we give amphotericin should be given over a duration of 4 hours. Amphotericin is nephrotoxic and it could cause side effects such as hypokalemia, bone marrow suppression, thrombocytopenia and fever. This should be remembered because sometimes if a baby is an amphotericin, if he has fever, there is no need to keep on searching for new infections. So to conclude, starting of antibiotics should be either empiric based on the clinical symptoms or should be based on the culture reports. Empiric antibiotics should always be based on the audit of previous cultures. Always practice the sending a culture before starting an antibiotics, as this would help us to choose the right antibiotic, and the antibiotic should be based on the type of organism, the sensitivity pattern, and the infection is at what tissue and what organ. The upgrading of antibiotics should always be protocol based and should be decided by more than one individual. Restrict the usage of antibiotics by decreasing the duration, by decreasing the use of broad spectrum antibiotics, and also by decreasing the use of reserve antibiotics. It is always better to know our antibiotics, whichever we are using in the NICU. We should know their dosage, we should know their side effects, and we should know their interactions for ensuring a good and a positive outcome of all our newborns. Thank you.